Okay guys, round two. This is my second video, Dr. Rebecca LaValle. Hi all you cool cats and kittens, like Carol Baskin over here. Alrighty, so today we're gonna talk about what happens if you get bit by a tiger. No, I'm just kidding, but kind of actually. So this is gonna be a little bit of it's a surgery rotation video. I'm going to focus on what you need to know as a primary care for surgery. So what surgical conditions do we need to know how to recognize, when to refer to surgery, and then also going to be touching on surgical procedures that we would do in the office, laceration repairs, incision and drainage, those type of things. So first and foremost, let's talk about some surgical conditions that we would see that we would, really need to be able to recognize. So a lot of this is just review for you guys, but again, appendicitis, we need to be able to recognize that, right? Right lower quadrant, McBurney's point, fever, abdominal pain that's worsening, that right lower quadrant, always think appendicitis. The other thing I want you to always remember is any female of reproductive age, which means they get their period, so it could be from 9 to 55, you need to do a urine pregnancy test. We need to always rule out pregnancy. If patients say, no, I'm not sexually active, or no, I don't want to do a pregnancy test, you could document that. At the same time, I always try to encourage them, if they're sexually active, to let me do one, because it's better to be safe than sorry. That's just, even if I just got my period last week. Yeah, but it could be bleeding during pregnancy, right? And not a real period. So always, always, always rule out pregnancy. Just a little tidbit there for you. So we always want to do that. Any abdominal complaints, urine analysis, urine dip in the office is helpful. It's cheap and it's helpful, so that's something we could easily do. Other surgical things that you may see are hernias. So what do we do with a hernia? If you can feel a hernia on exam, so you have inguinal hernias, you have indirect, direct, all different types of hernias. If you can feel a hernia on exam, then you can send that directly to surgery. If you can feel it, most surgeons would say, don't waste your time with imaging, just send it over to us. And if they want imaging to confirm, then they'll get, ultrasound or CAT scan. If you're not sure, then you can go ahead and get ultrasound or CAT scan. But if you feel something or you see something's abnormal, go ahead and obviously send it. Obviously, an incarcerated hernia, something that's sticking out and you cannot push it back in, that is a medical emergency, and that needs to get sent right into the emergency room. The other thing that we'll see a lot of, to be honest with you, is abscesses, right? Also pilonidal cyst. Pilonidal cyst is track in the pilonidal region of the buttocks, right in the upper cleft of the buttocks, and it can form a cyst there, okay, which we would call pilonidal cyst. The problem is we never know where they're really tracking or how deep they are. So if they come in acutely inflamed, the patient is going to need IND just for relief. If you can get them into surgery right away, perfect. But the main thing is they're going to need relief. So if you do IND that in the office, that's okay. You can definitely do that. Definitely wear a mask. It's going to smell putrid. It's okay. Just reassure the patient, like, this is normal. It's just these smell. Okay? Same as sebaceous cysts. They smell. It just is what it is. So you drain it, you give them some relief. So in the meantime, you could put them on antibiotics and get them into surgery. The main thing with the pilonidal cyst is they will keep coming back until they have definitive surgical treatment. So even if I drain one, I will send them to surgery, because it's an very, very uncomfortable thing for a patient to go through, and it's going to come back. So those are what I usually do with pilonidals. Let's see. The other thing, so those are some major ones we see. I mean, other surgical things, breast surgery. Maybe you would have seen that in your, surgical rotation. Any concerning breast lump mass needs to get sent to breast surgeon. General surgery usually will do it as well. They're trained to do that. So they would probably either do, based on what it looks like with mammogram and ultrasound, they would do either, fine needle aspiration or excisional biopsy. So those are some of the things that, your surgery rotation you may have seen. The other thing to mention for sure is you need to know how to scrub, right? So in case you are assisting in surgery, you're assisting in a C-section, we should be trained to be first assist. So we need to know how to scrub. And you need to know not just how to scrub, but how to gown and glove yourself. If you are in a stat emergency C-section, the tech is not going to be able to put the gown and gloves on you. You need to know how to do that and how to keep yourself sterile. So in that teachmesurgeryskills.com, there is an area there that I'd like you to watch, just so you can make sure and touch up on that, so you know how to get yourself sterile if you need to. That is for if you're going into the operating room. If you are doing an outpatient procedure, so we're doing an abscess, those are not sterile. They are just not. They're dirty. If you are doing a laceration repair, they actually have come out and said cleansing it with tap water does not increase infection rates. They have said that using non-sterile gloves, your regular gloves, that's okay. Doesn't increase infection rates. We still do try to use sterile gloves and, a sterile laceration repair kit. But just so you know, it's okay if you do use tap water to clean it. If you do use non-sterile gloves, they have been shown to have no increased infection rates. So let's talk a little bit about laceration repairs. So if someone comes into you and they have a laceration, why do we suture? So the reason to suture, I always think in the back of my mind, why am I suturing this? I'm suturing this for two reasons. One is to help the wound heal, right? And to stop bleeding, so hemostasis. The other reason I do it is for scarring, okay? And because to help it heal again. So if it's not bleeding and it's small and it's in a spot where who cares if you scar? I mean, could you leave it alone? Sure, you absolutely could. But it really helps to approximate them so that you're making sure that it's going to heal better. But is there times when you're like, okay, that's not worth suturing? Yes. If it's not bleeding and it's so tiny and it's in a spot where no one cares about a scar, it's okay. So if they come in and they're bleeding, the first thing you want to do is hold pressure, obviously. Now this is going to vary versus like primary care, urgent care, and ER. So ER, you're going to get some huge lacerations, and that hemostasis is maybe very difficult to get. So that's kind of a different beast, but we'll kind of go through it the best we can. So if it's not bleeding, we want to irrigate it as much as we can. If this is a really nasty wound, it was a car accident, it's got all sorts of pavement in it, those type of things, irrigate, debride, removal of foreign body, we got to do those things. Now that's when you're kind of like, okay, are we gonna do this with no anesthesia, or are they gonna go to the OR and get this done? So kind of that's an emergency room thing. But say you have a simple wound that you definitely can handle in the office or urgent care, and it's just dirty though. Make sure you irrigate, debride, go in there, try to get, and you can feel free to numb it first, right? So you're gonna numb it anyway to suture it. So use some lidocaine. You can use lidocaine with epi. as well. There really is no difference between lidocaine 1% and lidocaine 2%. There really has been not shown to be, as far as I know, any difference in anesthesia. So either one you have is fine. The epi will obviously help stop bleeding. So they used to say don't use epi like on the tips of the fingers or even the hands. They used to say not for digital blocks, not on the toes. Now they're saying you can use it as long as you're not worried about vascular compromise. So if this is a young, healthy person, you could use epi. If you're nervous about it and it's not bleeding a lot, then I would just stay away from the epi on the extremities, or like the nose or something like that. But if you need it for hemostasis, you can use it. So feel free to go ahead, and once you've cleaned up this wound as best you can, go ahead and feel free to inject some of that local anesthetic so you can do a better job of cleaning it, because cleaning out that wound is a numero uno. That is the most important thing. That is what is going to lead to your decreased infection rate. So we clean out this wound, and now we're thinking, okay, what are we going to do? We got to put this back together. So if it's a deep tissue injury, if you have like muscle involvement, then you're going to have to use layers, right? If you have, if there's like injury, the things that if you have a really deep injury of the hands, eyelids, nose, a nerve injury, open fracture, those things, I'll be honest, I would leave open, and they need to be seen within 24 hours by a specialist, 100%. Just as in general, another tidbit, wounds normally need to be closed within 18 hours. Head wounds, scalp wounds, you can do 24, but around 18 hours, we like to keep it within. So now you got wounds. So depending where the wound is, that's kind of how we're gonna like divvy up, okay, what are we gonna do for this wound? We've cleaned it out, we've got some, local anesthetic on it. What are we gonna do? The other thing to note, if it's a child, you can use a topical anesthetic like Emla cream or LET. LET is a combination of lidocaine, epinephrine, and tetracaine. That's mixed up. Some people actually, I think the hospital actually has it made up for you. It's compounded though. Or Emla, which is, I believe, prilocaine, lidocaine. And so you can put this on and leave it, for 10 minutes, 15 minutes, let it soak in. And then you can either suture just with that if they got pretty good result with that, or you can then inject the topical anesthetic, because now they at least have some, anesthesia. So the needle will hurt less. I do one of those two things when I suture children. Most times kids, if it's small and simple, we will papoose them. It's a little traumatic, it is for sure. In the emergency room, if it's extensive, then they will use ketamine or something similar. But for simple wounds, they usually just papoose them, and we hold them down, and we just put in the 2 sutures or 3 sutures as quick as we can. And it's a little traumatic, but again, you got to kind of do what you got to do, and it's a risk of anesthesia if not. So we don't routinely use anesthesia for very simple wounds in kids. So just as an FYI. Okay, so now we have this wound. Where is it? That's kind of what's gonna divvy up. Again, I'm gonna send you an AFP article that's pretty good to know what kind of sutures to use. So the main things to know, in the mouth. So let's start from the top, I guess, actually. Let's start at scalp. So in the scalp, there's not a lot of nerve endings. So that's why we usually use staples. And so staples are easy, they approximate it, and I'll be honest with you, most people, you could staple their head without anesthetic. But again, you can use it depends if you got 2 staples to do. Sometimes the people won't want anesthetic. They really won't. Be like, do you want the lidocaine? Do you not? Do you just want me to do it real quick? I'll be like, oh no, just do the staples real quick. So it kind of depends. The other thing is because the scalp is super hard to suture because we have hair everywhere, right? So that's why we usually use staples. There is a hair technique that you could use where you actually tie the hair together if it's a small wound, which sometimes on kids this will be nice. So you literally tie the hair, it's called the hair tying technique. You tie the hair on the scalp to close the wound, and then you could put a little glue over that. Otherwise, I don't usually glue in the scalp because of that. But if you got a kid and it's an actual technique, you could, look up, what's it? Let's see if I can find out what it's called for you. Yeah, hair opposition technique, that's the name of it. Okay, so you could do that if you wanted to. So those are your scalp wounds, and then, so you're usually gonna staple those. But if you wanna do the hair opposition technique with a kid or something, you could. Then you're gonna go to so we have facial wounds. So the thing about facial wounds, you are gonna want to use the lowest number of the suture, which obviously means it's the thinnest suture, right? So you're gonna wanna use your 6-0. And usually we would use like a simple interrupted, and you would use nylon usually, because they're gonna come out. And you want to take these out like usually in the face, if they're pretty good healers, like 5 days, because if you can take them out, you want, obviously if they're not ready to come out, they're not ready to come out. You can leave them a couple more days, but the longer we leave them in, then you can kind of get that railroading. So facial wounds are ones where we do take them out a little bit sooner. So remember, face 6-0, nylon, simple interrupted, and 5 to 7 days. If you are in the mouth, so I do not routinely suture in the mouth unless it will not stop bleeding or there is a gaping hole to where, obviously if it's communicating with the outside of the thing, then yes, you have to suture. You have to suture both sides. In the mouth, you can use absorbable, okay, if you need to suture. If there's just like a gash on the inside or a gash on the tongue and it's not all the way through, and I mean, if food's not going to get stuck in there, that will heal, and I do not do anything for it. If food's going to get stuck in it, or you're worried about it's not healing, it's bleeding, you can use an absorbable in the mouth, an absorbable suture. So that's where we're going there. Now we're to the body. So on the body, especially if you got, in the trunk, simple interrupted is fine. You can use mattress sutures too. There's horizontal mattress and vertical mattress. What those do is basically they take tension off. So in high tension areas, you're better off doing a mattress suture if you can. It's just a way that kind of brings the tissues up together. It brings those vascular edges together. If you can do those, that would be great. If not, if you're only comfortable with simple interrupted, if it's deep, you always want to close the space, right? So if you do simple interrupted and the wound is too deep, you will create a pocket, right, for fluid, infection, anything. And it may dehisce, it may, not heal. So you always want, if it's super deep, then you're going to have to do a layered closure. So then you would do an absorbable layer underneath, and then on the top you can do your nylon, your removable sutures. On the extremities or the trunk, I usually use a big suture, like a 3-0 or a 4-0 nylon, and usually you'll get a pretty good result with that. When do we dermabond, which is, the adhesive, the glue. I usually use that, you could use that on areas that do not have high tension. I would never dermabond the hand because it's huge high tension area, right? That usually needs a 3-0 suture. The only time I would do it is if you are gonna, like, say this person's super scared of needles, they can't do it. If they want to dermabond it, like say you had a laceration here or something, you could glue it, but then you're gonna put them in a splint, okay, for 5 to 7 days so that they cannot bend it, because the minute they bend it, it's gonna open up. Okay, so if you do have to glue something for some reason, you're out in the woods, you gotta glue something, basically what you're gonna wanna do is immobilize it if you have to. Okay, if you have a small little laceration here and it's a child, you could try to glue it and then do some steri strips if it's so tiny. If not, you got to kind of balance the trauma you're going to cause the child versus scarring. So you kind of have this discussion with the parents, like, hey, these are our options, okay? Suturing is always the best option in terms of wound closure and healing. But it's not always the best option when you weigh the pros and cons, right? So here, are you going to notice a little scar? Probably not. So do you really want to go through with it? Now, anything close to the eye, obviously, you don't want to get glue in the eye, so you got to be super careful. If a laceration crosses the vermilion border of the lip, that has to be sutured, absolutely. I mean, you're not going to want to use Dermabond there anyway. But so there are a few things. Bites are a whole nother beast. Bites, you are going to try not to suture. You're going to do your very best not to suture. If this is a huge bite, huge filleted open, you do some really loose kind of sutures just to bring it together, but you want to be able to let that infection come out. Never, ever, ever glue a bite. Don't glue a bite. Just don't do it. Every single bite, human, cats, dogs, everyone needs to be on Augmentin or a similar antibiotic with similar coverage. Just have to do it. Do it prophylactically. The other thing I would say, again, that for sure is recommended, okay, AFP. But in other areas, they don't recommend that you don't need antibiotics for lacerations. The AFP also says that, topical anesthetic or topical antibiotic creams on there are helpful. For the test, that's fine. I'll tell you in real life, I hate topical antibiotics on laceration repairs because they get wet, they get moist, and they break down, and they're all macerated, and they dehiss. So, and I've talked to other surgeons too who agree that if we can just leave it clean and dry, a lot of times it'll heal better. But again, AFP says you can use a, bacitracin if on the wound. I like to just say leave it clean and dry. That's it. After 2 days, well, you can wash with soap and water, do what you gotta do. But 2 days, leave the you put a non-adherent over it. Leave the bandage intact for about 24 to 48 hours, and then after that, you can wash with soap and water. Steri strips may come off because usually I'll put steri strips over the lac repair. If they do, they do. Let's see. So, what else was I talking about? So I was talking about bites. Oh, okay, yeah. So definitely use. Oh, so the other wounds, say you cut your arm on a can. Oh, that's a whole nother thing, because then you gotta get a tetanus shot. But anyway, wounds, any lacerations, they haven't had a tetanus in the last 5 years, you're gonna wanna give them tetanus. The thing I was gonna say though is antibiotics. So besides bites definitely need oral antibiotics, okay? Besides that, if it's a relatively clean laceration, they say you don't need oral antibiotics. That's where I got into talking about the topical antibiotics, which they say you can use, but I don't like. The only time I do prophylactic antibiotics, and this is not AFP, ABFM, I'm not sure what the answer on the test is, and I apologize for that. But True Life, just giving you it straight, lacerations on the hands. I have a much lower threshold for using oral antibiotics on hand lacerations. I have seen so many of them come back infected. Hands, they're dirty. We use them a lot. People are not going to not use them. So the only ones besides bites that I usually am like, oh, you need an oral antibiotic just prophylactically is hands. And I don't mess around with hands because we need our hands. So that's another one just to tidbit there for you. Then we talked about the face, taking those sutures out in like 5 days. They even say you can go to 3 days. It depends. If it's a kid, maybe 3, young, healthy, but otherwise 5. Scalp's going to be about 7 to 10 days for those. 10 days is fine for the staples. Arms, trunk, legs, palms and soles. I mean, hands, you're going to need a good 10 to 14 days. They even say 14 to 21. So that's a long time. But definitely 14. 10 to 14 for hands, feet, legs, trunk. Arms, maybe 7 to 10. So that's how long we're going to, leave those on. I think that's what I wanted to talk about for suturing. The other thing we could talk about would be I&D. So, or even, removal of moles, removal of those type of things. I may make a separate video for that type of thing. But for I&D, let's just quick touch on that. So the main thing for I&D, you have this huge abscess, it's fluctuant, you can feel the pus in it, it needs to be released. So I always give them the option. If you do it without, so the issue is you're going to put in the lidocaine, and as soon as you put the needle in, probably pus is going to come out, right? So it's like, what do we do here? But and it increases pressure, so then it can kind of not explode in your face, but wait till you cut into it, you've just increased the pressure. But the reason you need the lidocaine is not so much for the actual cutting, because the cutting open of the thing it's going to be painful, but it's also going to be a relief for the patient. It's the actual milking out of the pus after the initial incision. That's the painful part. So the lidocaine helps you so that you can get out as much as possible. So I know some people still do pack. The AFP, ABFM, as far as I know, does not encourage packing of wounds. If you want to pack, you can. It's hard for patients to change, especially if it's in a tough location. Depends on how deep the wound is. I do not pack. I do let the patients know that it may reaccumulate, and that, if it's a recurrent issue, then I send them to surgery for definitive treatment. But most of the time, it works fine. Also, they say once you do the incision and drainage, you don't need oral antibiotics. That's up to you. Based on how inflamed it is, you can kind of, use them or not use them based on your judgment. But the answer in the book is going to be just I&D with no antibiotics. But if there's a big component of cellulitis there too, a lot of times I will put them on antibiotics because, think about it. You can have a skin soft tissue infection and abscess together, and for cellulitis we would do antibiotics. So it's a fine line there for sure. So usually I will infiltrate with 1% epi with lidocaine, 1% lidocaine with epi, depending where it is. And then I'll use, a 10 blade or 15 blade scalpel, and I'll make a small incision in the center, feel where it's most fluctuant, and then I will, do that. And then you'll have pus come out. And if you don't have pus come out, then either you're in the wrong area, or maybe it was a bad cellulitis and you just thought you felt a pouch. But as long as you've numbed it, usually what I'll do is I'll take a curved Kelly clamp, and I'll explore the area, because a lot of times you can have an abscess that has a membrane in between. So you'll get part of it, And then if you take that curved Kelly and you come in the wound, you can break open the there's like a little fascia in between the two abscesses, and then you'll get more pus. So you always kind of want to explore the wound as much as you can, just to make sure you're getting everything out. So that, and we see a lot of MRSA, so if you are going to use antibiotics, I usually use ones that cover for MRSA if it looks suspicious. Just no IV drug users. I'm very, very, very careful with INDing those. I do not like to do them on an outpatient basis, and the reason is they need blood cultures. A lot of times those blood cultures will be positive, and these people are at high risk for endocarditis and sepsis. And I've seen this happen multiple times. So if you have an IV drug user with an abscess, they absolutely need blood cultures. If they have fever or their vitals look funny at all, they need to go to the emergency room for sure. So that's another little tidbit. I'm trying to think what else I can tell you about. So laceration repairs, abscesses, pilonidals, and then obviously we got our sebaceous cysts. The sebaceous cyst, if it's not inflamed and you're just taking out the sebaceous cyst, there's like it's in like a cover. It's like what is it called? It has a covering on it, right? And you gotta get that out, or else that is gonna it's gonna come back. There's a capsule. It's like in a capsule. So you gotta get that out, or else it will come back. So, but we can take those out in the office easily as well. Usually I will, if it's a small incision, I will just leave it open. I mean, I don't suture those closed. The only time I'll suture those, like a removal closed, is like if you were doing a big lipoma or something, where you needed to, or you did a big mole removal where there's a deficit. But like for an abscess or anything, just let that infection come right out. Warm compresses always help expel. Wash in soap and water, keep it clean and dry, and usually they heal up. All right, I think that was it for my surgery quick tutorial of what you need to know for surgery rotation. I will be back soon with more videos, and if you have any questions, feel free to leave them in the comments. Hit subscribe. I will try to make as many videos as I can for you guys. And yeah, if you think of any topics you really want me to, make a video about, or you want to know more about something, feel free to email me, text me, call me, anything. Okay? All right, guys. Thanks so much.